Hello, I am Junho Jung from the Medical History in Modern Korea. The 1960s in Korea is often referred to as the era of developmental dictatorship. It is characterized by the pursuit of state-driven industrialization with economic development as the top priority. But the development of civil society and democracy was suppressed in order to achieve the economic goal. At the same time, the field of medicine experienced an explosive growth alongside the growth of the Korean economy, and the institutions and the practices created during this period still have strong influences on Korean medicine at present.
Revision of Health Center Act.
In 1962, the Health Centers Act was completely revised. It consolidated many of the existing health centers that had fallen into despair, reorganized unevenly distributed health centers, and established one health center for every 100,000 people in urban areas and one in every county in rural area. After 1962, a nationwide network of health centers was established, and a wide range of national public health projects was carried out through those centers. Especially in the 1960s, when the nationwide network of health centers was formally completed, they became an important conduit and an implementation channel for foreign aid. The government's financial investment during this period was limited to supporting the labor cost of each local health centers, but the actual project's costs were mostly covered by the aid funds. Thanks to foreign aid and technological advances such as the development of anti-TB drugs, National TB control system could be established, especially through the health centers. Before Korea became independent, the only treatment for most cases of tuberculosis was convalescence, or in severe cases, surgical intervention, which required large-scale convalescence facilities, or specialized medical personnel to perform surgery. This made it virtually impossible for the state to organize the management of large numbers of infected people. However, with the advent of chemotherapy with antibiotics, it became possible to manage patients in their own homes through medication, rather than based on isolation and convalescence. In 1961, the government signed a technical agreement with the World Health Organization on TB control, and in 1962, it received material support from UNICEF. And then in 1963, a TB officer was appointed in each city, and TB control workers were deployed in health centers across the country. Along with mobile screening teams, these workers detected patients through sputum testing, registered them at health centers, and administered treatment to them. In addition, health centers were established in each administrative district, where TB control workers could register all patients in the community and administer treatment through home visits. According to the first TB survey in 1965, the prevalence of TB among the population aged 5 years and over was 5.1%, and the proportion of infectious patients was 9.9%, leaving 1.24 million patients in need of treatment. By 1970, vaccination units centered on health centers had vaccinated 2.84 million people with a total of 1.12 million registered treatments and 218,000 cures.
Revision of Infectious Disease Control Act.
Population and infectious diseases were a major concern for Korean medicine in the 1960s. Despite the post-war recovery of the 1950s, infrastructure remained fragile, and rapid urbanization accelerated the spread of infectious diseases, such as tuberculosis in densely populated areas. Against this backdrop, the Infectious Disease Control Act was completely revised in 1963. The most notable change was the expansion of the medical examination section of Article 8, which required students and workers in workplace with 15 or more employees to be screened and vaccinated against tuberculosis at least once a year. Along with the enactment of the School Health Act, this laid the foundation for a large-scale national school-based screening and treatment program. We will discuss on this later. In addition, since the mid-1960s, there has been a range of legislative activity in support of the Infectious Disease Control Act. These include the Parasite Prevention Act of 1966 and the Tuberculosis Prevention Act of 1967. In short, this was an active period of legislation on health and disease. Targeted infectious disease control bills were enacted. Private organizations could be appointed to manage them. And school-based screening and treatment initiatives were promoted. Acute infectious diseases plummeted throughout the 1960s. As a result of the expansion of epidemic prevention method, widespread immunization, and the development of epidemic control initiatives, smallpox, which had exceeded 40,000 cases in 1951, was eradicated with the last case reported in 1961. And typhus, one of the major epidemics of the Korean War, was virtually eradicated from 30,000 cases in 1953 to the last case reported in 1966. The epidemic that was on the rise throughout the 1960s was typhoid fever, which was particularly prevalent in large cities such as Seoul and Busan. Partly due to the dense population and urbanization, it was partly because poor water supply and partly of inadequate hygiene control and regulations in restaurants in relation to the growing food industry. Paradoxically, the expansion of antibiotic use also played a role. Domestic production of antibiotics increased in the 1960s, and access to the drugs improved. Typhoid patients in urban areas would purchase and take antibiotics on their own before visiting a hospital. This would not kill the typhoid bacteria, but it would make them less symptomatic. Instead, symptoms were often masked, making diagnosis difficult, and they became carriers of bacteria. This increased carrier population led to a sustained urban epidemic of typhoid fever, which was characterized by frequent relapses and complications, such as intestinal bleeding and perforation due to the self-administered antibiotics. Poor access to healthcare resulted in a very high fatality rate of 9.3%. Compared to the 0.2% among farmers who were systematically treated at rural health centers, the antibiotic paradox.